Our first speaker is Professor Martin Cormican. Martin graduated from NUIG Medical School in 1986. He trained in Ireland, the UK and the USA. He was appointed consultant microbiologist in Galway University Hospital and professor of bacteriology in NUIG in 1999. Since May 2017, Martin has been the national lead for healthcare-associated infection and antimicrobial resistance. Since February 2021, he is the clinical lead for COVID-19 vaccination rollout. His research interests are antimicrobial resistance, foodborne infection, and the links between the environment and human health. And I'll just add that Martin has been a great friend to the Department of Agriculture. He's a regular participant, and anytime we ask him to get involved in any initiative, he never says no. So over to you, Martin.
Thanks very much, Caroline. Okay. Slides are displaying, and so thanks for the opportunity to talk about this evening. I'm going to turn off my camera just to. Okay, so I'm going to start just with a short clinical story about a 43-year-old woman, and this is a fairly typical story. Somebody who develops some stinging pain passing urine, probably has a bladder infection yesterday, and then wakes up this morning with a fever and pain on the right side. As the day goes on, getting worse to the stage that feels really unwell, high temperature, barely able to stand, comes to the emergency department, and after she's examined, the conclusion is that she probably has sepsis coming from an infection of the kidney or pyelonephritis. Blood in the urine supports that, and we get a urine sample to grow bacteria, we get a blood sample to grow bacteria. Now, one of the key things about this situation is that because she has sepsis, we know that every hour in delay in starting the antibiotic increases her chances of dying by about 8%. So it's really important to get the right antibiotic and to get it fast. The bacteria in her blood and urine, we may know what they are tomorrow, but she needs to start an antibiotic now, and the question is which one. And then that's sort of an everyday scenario that I'm just going to talk about a little bit. And not in mind when I was thinking about this talk, you know, if you know the song "I Will Survive," I should have changed the stupid lock. I should have made you leave the key. And I think locks and keys are a good way to think about one of the points about that the minister referred to there, about the commonality of antibiotics. So next thing I'm going to talk about very briefly is the anatomy of a key. So there's, believe it or not, a very comprehensive website that tells you about the anatomy of a key. And you can see that there's the blade, the shoulder, and the bow of the key. And antibiotics work a bit like a key that fits into a lock. So an antibiotic is like a molecular key. It fits into a very specific molecular lock in the bacteria, and turning the key in that lock kills the bacteria. Those locks are very special locks because if you want an antibiotic is supposed to kill the bacteria, but it's not supposed to kill me. So it has to fit into a lock that is present in the bacteria, but that is not present or is very different in humans. And that's the key to antibiotics, is this, the so-called selective toxicity, which is based on that fit between the blade of the antibiotic, as it were, and the lock in the bacteria. So when we talk about a class of antibiotics, like the tetracyclines, people will be familiar with names perhaps like tetracycline and oxytetracycline and doxycycline and minocycline. They all sound a bit different, but the key point here, the parallel with the key, is that all of them have the same blade. The bow and the shoulder may be different, but they all essentially have the same blade, and so they all fit in the same lock. And that's why we call them a class. If you take another example, for example, the penicillins, there are hundreds of penicillins. but they all essentially are keys with the same blade, and they all fit in the same lock. So sometimes it looks like there's a bajillion different antibiotics, but what really matters is how many classes of antibiotics there are and how many locks we have to attack in the bacteria. And there's a lot less locks than you might think based on the number of names of antibiotics. So the term veterinary antibiotics and human antibiotics really don't mean anything very much, because they're usually using the same blades and they're usually targeting the same locks. And that's why I call this talk, we're all drawing from the same well. So if the locks change, and this goes back to Gloria again, or you will recall that she wished she'd changed the stupid lock. He wouldn't have been able to get back in the good for nothing that she'd gotten rid of. So bacteria can change the locks. And that change in the lock comes because of a genetic change in the bacteria. Of course, there's only value in changing the lock if somebody is trying to get in the door. So if there are no antibiotics around, if nobody's using a key with that blade on it, then a new lock makes no difference. And that's this key thing, this thing about why using antibiotics drives resistance, is bacteria tend to change locks naturally, but the changed lock is only valuable if we make it valuable. And the way we make it valuable is by using antibiotics. And that's that's what drives that. And once a lock becomes established as having an advantage, then it tends to persist for a long time. So antibiotic resistance can emerge fairly quickly. And unfortunately, when we stop using antibiotics, it takes a long time to wear off. So we're going to be at this for a while before we get antibiotic resistance under control. And of course, the new locks don't stay put. Once the new lock becomes common in a type of bacteria, it can jump to other type of bacteria, and the bacteria we know can move between humans and animals and the environment, and they can bring the new locks with them. So the bacteria move, and the gene that codes for the new bacteria can move, and that increases the ease with which antibiotic resistance spread. So the woman I described to you probably has an infection with the bacteria called E. coli. E. coli is a very common bug. We all have trillions, bajillions of it in our gut, and so do all farm animals. And in the 1960s, if we were treating sepsis in this woman, we would probably have been very confident that ampicillin would have killed the E. coli. By the 1980s, we weren't confident that ampicillin was going to work anymore. And now less than half of E. coli are killed by ampicillin in our lab. And I don't mean hospital E. coli here now. I mean just regular E. coli causing bladder infections in the community. Less than half of them are now sensitive to ampicillin. So much so that all our guidelines say now you can't use ampicillin first line to treat a simple urinary tract infection. In the 1980s, when I graduated medical school, we could count on these drugs called Kefataxine. Some of you may be more familiar with Kefatiofur. When I was looking up some old papers around this last night, I saw something from 2002 which described Kefatiofur as an antibiotic developed specifically for use in animals. And of course, this doesn't make really any scientific sense. Because as to talk about that key earlier, Kefatiofur and Kefataxine have essentially the same blade and they fit in the same lock. The shoulder and they may be different, but the piece that works is essentially the same, and really all cephalosporins for practical purposes. So by the 1990s, when I got my job in Caroline and came back to Ireland, Kefataxine was becoming much less reliable because of this thing called ESBL, or extended spectrum beta lactamase, which was, if you like, a kind of lock that the bacteria had acquired that meant that the Kefataxine didn't kill E. coli as well as it used to. And when I came back in '96, one of the first papers I got published was a paper saying, oh, look, we found some E. coli in Ireland that are ESBLs. And at that point, that was rare enough that we were able to write about it. 20 years later, ESBL E. coli was everywhere. We can find it in humans and animals. We can find it in the water. and it's now it's now all over the place in the space of 20 years. So, if we're looking at the woman I described to you in the hospital tonight, what antibiotic are we going to use? We can't count on ampicillin anymore. In '86, when I graduated, I could have counted in Kefataxine. I'm not sure I can count in Kefataxine anymore. We do still have options for her. And remember, if we get this wrong, her chances of recovery decline fairly quickly. We do still have options, but those options are getting fewer and they're getting harder to find and harder to use. Has this anything to do with animals? Well, so one of the questions sometimes people say to me, well, does the E. coli in this woman, did it come from an animal? And the answer is probably not. It probably came from her own gut. Now, it could have got to her own gut from a food that she ate, and we know that you can pick up bacteria from the food that you eat, of course, and you can pick up bacteria from animals in the food that you eat if it's not well cooked. But most of the time, the E. coli that cause infections in a person like this are a variety of E. coli that is mainly associated with humans. But what's important is that the genetic code for the new lock that makes it ESBL, we find that genetic code in both animals and humans, and it moves around. So even though in this case, the bug has probably not got an animal origin, the fact that we have E. coli in animals and humans and that we have genetic code that moves around the place means that anything we do in one sector to drive antibiotic resistance impacts on other sectors. So I was just going to mention briefly how does SARS-CoV impact on our work on antibiotic resistance over the last few years. And it's been a mixed bag, but one of the things it's done is it's tended to increase certain antibiotic use in human health driven by misinformation. So SARS-CoV is a virus, and antibiotics do not make you get better faster. But there's a lot of information on the internet about certain antibiotics, and Nuala and I were just talking about this earlier in the week about trying to manage that misinformation that the antibiotics don't work. The second thing that's driving antibiotic resistant use with COVID is that although the virus doesn't benefit from antibiotics, sometimes the virus is followed by a bacterial infection, and that can drive antibiotic use. And then the other issue with SARS was so much energy and focus has gone into dealing with SARS that we haven't been having had the same energy and focus on antibiotic resistance in the last couple of years as we've had in the past. We have kept a lot of the work going. It's not like it stopped, and there's been a huge effort to get things back moving again. But there has been some disruption to our work in the last couple of years, so it's been challenging to manage the impact. There has been progress in hospitals. The hospital antimicrobial stewardship systems are much better than they were. The systems for infection control in hospitals are better than they were. And some of the investments and work that's been done around the pandemic, we hope will have long-term benefits. We've done a lot of work on providing training and training materials. A lot of this material, some of it may be relevant to animals or maybe of just general interest. If you want to, anybody can look at these training materials about infection control and so on HSE Land. And today, in addition to the launch of INAP2 that the Minister mentioned, the HSE also launched its plan today for antibiotic use in 2022 and 2025. And for the first time, and this is, I suppose, learning from the veterinary side, we've set targets. Now, I heard the Minister talk about a 50% reduction. Our targets are ambitious for the human health side because we're saying we want to get a defined percentage reduction, but I'm afraid we don't expect to reach 50% in 4 years. But I think we have set our cap at getting it down and getting it down progressively. So the key points, I suppose, of what I'm saying is antibiotic resistance is not in the future. It's here, it's now, and people like that woman that I described are our everyday work in managing infection that requires hospital care. We're all drawing from the same well of antibiotics. There are lots of different antibiotics, but actually very few blades on the keys, far less than most people think. And when a new lock emerges, all the keys using the same blade, they all stop working. So not only are we all drawing water from the same well of antibiotics, but we are all drinking from the same pool of bacteria and bacterial genes as well. And when the new lock emerges, it can spread very quickly. And a lot of our work in the last 5 years, and certainly before COVID, was trying to stop the next big bug. I mentioned ESBL. Well, some of you will remember in 2017, a bug called CPE was declared a public health emergency in Ireland. And a huge amount of work went into stopping CPE becoming as widespread as ESBL has become. And so far, so good. We have held that in check. But you're only as good as your last performance. But so far, over a number of years, we have gotten that into some kind of control and kept it in check. So the most important points, I suppose, to finish are, we do know how to fix the problem of antibiotic resistance. We are making progress, if we keep the focus on it, we can make this better and keep antibiotics working for the animals and the humans for now and for the future. And that's it. Thank you very much.
Thanks very much, Martin. I think lots of sobering thoughts there in that presentation, particularly, I suppose, around the whole One Health message and handling antimicrobials with care, given that we do have this sharing of the same bacteria and sharing of the same antibiotics. So we're going to move on now to our next speaker. We're delighted to have Dr. Nuala O'Connor. Nuala graduated from UCC in 1986. She has worked in general practice since 1990 and is a founding partner of Elmwood Medical Practice. Like many doctors, she is active at national level in promoting change and improving standards of care for patients. She is the Irish College of General Practitioners lead on prevention of healthcare associated infection, antimicrobial drug resistance. So I regularly hear Nuala being interviewed on Morning Ireland, so she's a very busy person and we are delighted to have her here. So over to you now, Nuala.
Thank you, Caroline. So obviously I'm a GP, so I work in the community, and following on from Martin's talk, I wanted just to try and share with you a little bit about what we've tried to do in the community over the last couple of years to try to tackle this growing problem of antibiotic resistance. So on the one level, you might think that combating the problem is easy. I mean, we should just use less antibiotics in the humans, animal and the environment, and we should use more narrow spectrum to target the infection that we're treating in the patient, or even indeed in the animal in front of you. And particularly in human health is not to prescribe for obvious viral infections. And in theory, it's all very easy, but except in that particular moment, my child is sick now, doctor. I'm worried.
Sorry,
I don't just have an antibiotic to be on the safe side. I have to be at work tomorrow. I always need an antibiotic to get better from X. So it's that human a factor that comes into play when in our interactions, which I think is probably slightly different to the veterinary world, although I suppose you're interacting with the farmers who want to mind their animals, or people who want to maximize well, I have the wrong term, so I'll just move on from that. So I suppose one of the things.
Could I come in there, Nuala? We can't actually see your slides.
Oh my gosh, why is that now? Sorry, something happened on the camera bit here. I don't know. I seem to be. Hang on a sec. Just do one other thing here. I'll share my screen. Try this again.
Yeah.
Okay. You see now?
We can't see the full screen. Your follow-on slides are to the left. If you go to
yeah, I'll do. Yeah, I will do that. Play from the start. Okay. Sorry. Apologies.
Yeah. Perfect. Thank you.
Apologies. Sorry. So you can hear me. You can hear me all right. So so that's what I just mentioned there. So just move on. So a couple of things that we've tried to do with GPs to try to help them. So one of the key things is having good antimicrobial prescribing guidelines. So we have a website, antibioticprescribing.ie, and this is put together by a team, multidisciplinary team of experts And it's all about trying to have the most up-to-date information and easy prescribing tips and ways to prescribe, tables about dosing and everything like that. So it's just at your fingertips in general practice. And a big focus we have is on avoiding patient harm, where a safer, effective alternative is available. And just to illustrate a story with that, there was one patient, she was a 55-year-old teacher, and she was on a drug which was for anxiety, depression. She was only still on a small dose of it. And when she had a kind of a chesty cough, a lot of what people have now, even with COVID, she went to see her GP, and it wasn't the usual GP that saw her. And she never mentioned that she was on this this medication. And the doctor prescribed an antibiotic called clarithromycin, which is a macrolide. And what they didn't realise, because she wasn't on it, and was that there's a potential interaction between that and the drug that she was on. So this lady was otherwise quite fit and healthy. But what happened was she got that interaction. She got a short arrhythmia, and she actually fell down the stairs, had a serious head injury, and ended up with a subdural hematoma. Now the story ends well because she actually recovered completely. She and had no sequelae after it. But it just shows you how easy it is to combine one drug with another drug, and maybe sometimes people don't even realize that there's a potential combination there. So one of the things we've tried to focus on is to get people to look and prescribe the safest and most effective antibiotic for the person who's in front of you when you do choose to prescribe. Another thing that we've done is we've created what we call the green-red prescribing. So these are mouse mats, so we have mouse mats and posters and various little aids to help GPs. So the green means those antibiotics that are there on the green. The vast majority of things that we see and treat out in the community, you can do so effectively using a green antibiotic. It doesn't mean that you can't use a red antibiotic, but they should be avoided first line, and they're very specific areas where they would be the first line drug. And so what we've done is been communicating through various different mediums with GPs with targeted messages about how they could improve their green percentage, and above all, always focused on avoiding patient harm. And what we've managed to achieve with this is when we started, there was just a little under 50% of antibiotics were from the red category, but now it's more like almost 70% of the most recent stats are from the green category, and just over 30% in the red category. And in particular, we focused a reduction on some of those more broad spectrum antibiotics like the fluoroquinolone, second gen and third generation cephalosporins, and in particular we tackled comoxiclave, which was the most commonly prescribed antibiotic when I firstly got involved in this area, and it's now some time since we knocked it off its top slot. So we've made great strides with regard to quality of prescribing. We do have a bit to go with regard to quantity, and that's another thing that we're going to try to focus in some of these quarterly feedback reports that we're giving to GPs about their own prescribing. In terms of the COVID effect, well, during COVID, as you know, everybody was staying at home for a while. People weren't in school, nobody was doing social mixing, so of course there were no viruses spreading around other than COVID. And what we saw in COVID is that there was an absolute fall off in antibiotic prescribing in the community. So if you look at this slide on the left hand side, that's focusing on a January 2020, and remember when we had the peak, and what you can see is that 2009 is the sort of more vivid green, and the smaller column of green is the community antibiotic prescribing during that month. But unfortunately, as society has opened up, and as we know at the moment, there's a lot more than COVID circulating around. There in the early parts of 2021, I mean, we hardly saw any sick children, and our paediatric wards were actually empty. But if you look across there, the other month that I've highlighted is October of this year, and you can see that the two green lines are almost matching. So unfortunately, the quantity of antibiotic prescribing is bouncing back, and it's an extremely challenging environment out there in general practice, to try to curb this. Now, we've maintained the quality, which I think is extremely good. The other area, just to show you what happened in general practice actually during COVID-19. So this is just some data from SouthDoc. So SouthDoc is the out of hours service provided by GPs to the population of Cork and Kerry. And this, we're going back to 2020, and you can see there the grey is actually face-to-face visits in the treatment centre, and you can see as COVID, the world became, and Ireland became gripped with COVID, there was a complete flip around to us doing telephone consultations, which are in blue, and we still maintained a few small home visits. And right throughout that time, we actually maintained the quality of prescribing with still very high levels of green prescribing. But unfortunately, the quantity is starting to bounce back. Another area that we've looked at is our long-term facilities, and I just want to focus on one thing, which is prophylaxis. So when we've looked, and last year our community antimicrobial pharmacists went out visiting these facilities, and they could see that there was quite a lot of green antibiotics being used for treatment, and in particularly for prophylaxis. For urinary tract infections. But unfortunately, we had quite a high amount of residents on prophylaxis compared to the EU average. And the recommendation for prophylaxis is that it should actually be reviewed and perhaps stopped if possible after 1 year, but many were on it for more than 1 year. So it's new to us to have community antimicrobial pharmacists at CHO level able to do visits out into long-term care facilities. And this slide is just to show you what an amazing achievement they have given in a very short period of time. So if you look to the right, they've actually reduced the percentage of residents on prophylactic antibiotics from just over 6% to just over 3%. And that's by being out there, giving people back their data at local level, promoting antimicrobial stewardship, promoting the guidelines, and just being there, and that voice helping to lead people towards safer, better prescribing. So in terms of challenging combating antimicrobial resistance into the future, the question I would pose to people is, what have we learned from COVID-19? Because with COVID-19, we had an infection, no natural immunity, no effective treatment, and no vaccine. And we saw how fast it spread around the world. So Martin, and I know in your world, has shown you, and we all know that these multi-drug resistant organisms do the same. They spread in people's guts, they can spread on your skin. So AMR is this quieter, more silent pandemic, but has the potential to be far more deadly than COVID if we don't tackle it. We've learned now, and I think the world has learned a lot more about the importance of preventing infections through immunization, and how we prevent infections through good IPC measures. So in terms of being able to use our current antimicrobials wisely in humans, animals, and the environment, it's not something that can be solved by medical prescribers or veterinary prescribers. Like COVID-19, this needs every single person in this country and our governments and the world to take responsibility. So I suppose that's the key message that I would like to leave with people, is that perhaps we could take what we've learned from COVID-19 and try to apply it in the way we're trying to tackle antimicrobial resistance. And perhaps over the next 5 to 10 years, the world is truly going to look a different place. Thank you.
Thank you, Nuala. Some really important messages there. I think the key one being about everyone taking responsibility. And I suppose that's where Act 2 is heading in terms of, allocating responsibility across the human health, the animal health, and the environmental sector.